Good afternoon, everyone. It's 12 o'clock, so we're going to get started. Welcome to our cardio webinar, From Prescription to Practice, Tackling Adherence Challenges in Clinical Care. I'm Dr. Michael Constant, the Principal Investigator of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardi-OH, and I'm joined by Dr. Sherry Boland, Co-Principal Investigator of Cardi-OH. Founded in 2017, Cardi-OH's mission is to improve cardiovascular and diabetes health outcomes and eliminate disparities in Ohio's Medicaid population. Cardi-OH brings together Ohio's 7 medical schools to identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. To learn more about the collaborative and to access our online repository of best practices, please visit our website, cardio.org, and download our web app. I would like to acknowledge and thank our sponsor, the Ohio Department of Medicaid, and our administrative partner, the Ohio Colleges of Medicine Government Resource Center. I would also like to recognize the partnership of Ohio's 7 medical schools who contribute to make the Cardio Collaborative a success. Dr. Boland will now provide some logistics regarding today's webinar.
Thanks, Mike. Good afternoon, everyone. Just some brief reminders that if you would like to put your first and last name up so we can see that in Zoom for attendance purposes, that would be fantastic. If you're joining as a group, please use the chat feature to record names and emails of those that are in your group with you. If you're going to submit questions, and we hope that you do, use the Q&A feature to submit questions at any point, and we'll answer those during the Q&A portion of the webinar. And lastly, we will have a post-webinar evaluation survey to learn more about what you liked, what we can improve for next time. Next slide. No one has any disclosures for this particular talk. And if you are interested in CME, it is available. You need to have registered and claim that you're interested in receiving CME credit or checked that box to receive an email from Cloud CME. So if you are interested and you didn't do that, you can use this QR code to do that really quickly now or at the end. And there's also a URL in the chat that you can use to register and claim, mark it that you're interested in CME. Next slide. And with that, I'm going to turn it over to Dr. Amy Zack, who will introduce our speaker today. And Dr. Amy Zack will be moderating for us. She is a family medicine physician and vice chair of education at Cleveland Clinic and faculty at the Case Western Reserve University School of Medicine. Dr. Zack serves as our head of education and dissemination for Cardi-OH. So take it away.
Thank you. Thank you so much, Dr. Boland. It's my pleasure to introduce our speaker today. Dr. Robin DiMatteo is a distinguished professor emerita of psychology at the University of California, Riverside, a licensed psychologist and former health outcomes researcher at the Rand Corporation. Since she received her PhD in psychology from Harvard, she has been studying communication in medical settings and is the author of over 150 research papers and 8 books on health psychology and healthcare delivery. Her most recent book is from Oxford University Press, published just last year in 2025, entitled Health Behavior Change and Treatment Adherence, Evidence-Based Guidelines for Improving Healthcare. Although her favorite part of a 4-decades-long career at UCR was teaching psychology, pre-med, medical, and postgraduate students, Dr. DiMatteo has delivered invited lectures and trained healthcare teams at over 60 major medical centers, group practices, employer health coalitions, and nationally based health plans. She has developed and validated training programs to improve communication and adherence towards the goals of improved medical care outcomes. Her focus is on building clinician-patient trust and commitment to health behavior change in the management of long-term chronic disease regimens, particularly among patients facing socioeconomic and other challenges. So please join me today in welcoming Dr. DiMatteo to speak on From Prescription to Practice, Tackling Adherence Challenges in Clinical Care.
Thank you so much. I'm delighted to be here today to talk about treatment adherence. It's a topic that is incredibly important in clinical care and that has been researched for a very long time. What I hope to do today is, first of all, let's look at our identifying components of successful treatment adherence, understanding barriers to treatment adherence, and employing communication practices in the clinical setting to improve overall adherence of patients. I would like to acknowledge Leslie Martin and Kelly Haskard-Zolniak, who are the co-developers of the model that I'll be talking about today, the Information Motivation Strategy Model, and they are my co-authors on our book, Health Behavior Change and Treatment Adherence, published by Oxford University Press. A couple more goals today as I kind of want to give you an idea of what I'll be doing. As we try to unpack ways to understand and manage patient adherence, I'll be providing some of the evidence base for this area of research that has been around for a very long time. Obviously, within cardiovascular disease and diabetes health management, there are many challenges that are faced both in helping patients to be adherent to their medications as well as to follow important health behavior changes that they may need to engage in that are lifelong challenges. Within the populations, particularly Medicaid populations, we certainly see patients who have more vulnerabilities and more challenges in facing some of the things that are required of them to adhere to their treatments. I would like to acknowledge the talk by Dr. Robert Saper from December, in which he looked at just how important it is for us to consider the patient within the socio-ecological context of their life. As healthcare teams work together through communication with patients and communication with each other, they are working with their patients who are embedded within a social network. And we're going to come back to that point a few times today. I want to emphasize the importance of every touch point, every health professional, every clinician who interacts with the patient to both model and inspire and educate and encourage healthy actions and awareness by clinicians as well as patients of the challenges that can occur. All of this done within the context of caring and empathy. I want to just acknowledge that for many clinicians, adherence is sometimes thought of as just another thing to do. When we talk today about the statistics in treatment adherence and just how difficult it can be, some of those statistics can be a bit discouraging or overwhelming. And it's important to acknowledge that some patients can be somewhat frustrating. There's little time, often in practice, and there are fewer opportunities than there might have been in the past for long-term relationships and knowing the context of each patient's life. Certainly, prevention of non-adherence and early detection of non-adherence are preferable to trying to pick up the pieces after we find out that our patients have been having difficulties with the treatments that were recommended to them. So what I'll try to do today is try to present some essential elements of an understanding of the factors that affect adherence and what to do about them. I want to talk for a few minutes about the history of treatment adherence research. I don't want to take too much time with that because I want to provide you with actionable clinical steps. But I do want to make sure that we are very clear about just how strong the empirical evidence is for what we can recommend to do in patient care. The first research on treatment adherence began in the 1940s. And interestingly, the frame has changed in terms of how many people are looking at treatment adherence. Through the 80s, the word compliance was used a lot. Does the patient comply with what the doctor intended? And that in itself can provide us some clear clues that things might have gone a bit wrong. the term was changed to adherence. Sometimes the term concordance was used as an outgrowth of some of the focus on shared decision making. Just to give you an idea of the interesting ways that this might have been looked at, in 1978, an article was published in the New England Journal of Medicine, and it was about taking care of the hateful patient. And this seems kind of funny to us now, but the notion that patients who were non-compliant were considered self-destructive and deniers really reflected a little bit about the sense of rigidity almost that occurred in relationship to patient struggles. The author does recommend maintaining compassion, which is really an important element, and setting realistic expectations. But over the years, we've come really further than that kind of notion of digging in one's heels and pushing back against the patient. The history of adherence research, as I said, began in 1948, and two notable figures, Mary Hardy and Angelo Taranta, physicians who began early in the whole history of treatment adherence. I had the great fortune to work with Angelo Taranta, who was chief of medicine at the Cabrini Medical Center in New York City, and to do my dissertation research at Cabrini. The corpus of research amassed tens of thousands of research papers. There's a lot of stuff that's published. Most helpful are studies that are meta-analyses, randomized controlled trials, large cross-sectional studies. In 1982, Dave DiNicola from UCR School of Medicine and I published a book called Achieving Patient Compliance, reviewing at that point over 30 years of research in treatment adherence. And in 2025, lots of decades later, Kelly and Leslie and I published Health Behavior Change and Treatment Adherence, still trying to chip away at what is going to work in helping patients to be adherent, all the while keeping in mind that we are talking about human behavior, which people have been trying to understand for a really long time. As recently as 2020, non-adherence has been described in the literature as an unmet challenge, barely on the radar of practicing clinicians. I kind of not entirely sure that's true, because I think most practicing clinicians have at least back of mind the worry that their patients are not following their treatments, and as an epidemic hiding in plain sight. Keeping in mind that human behavior is the wild card in healthcare, we are always trying to understand, even 70-something years later, what to do about changing human behavior. This is not just a problem in the United States. It is a global problem. Recently, in 2025, the European Society of Cardiology provided the report from a working group on cardiovascular pharmacotherapy, and pointed out that globally, only about 40 to 60% of patients follow recommended treatment guidelines for medical therapies that we know really work. Non-adherence in chronic disease, just to give you an overview. So I'm summarizing 70-something years of research, and on average, 1 in 4 patients walk out of your office and do not adhere to their medication or to the treatment recommendations. There's a great deal of variability, and we're going to talk about what that is so you can be more attuned to adherence problems that may occur in different settings. But keep in mind that an initiation of therapy, what's called primary non-adherence, on average, about 15% of patients don't even start their treatments. It's higher for some medications. Maintenance, or persistence as it is called, that is following at least 80% of a treatment regimen, after 6 months in chronic disease, 25 to 50% of patients have stopped their treatment. Miracle drugs. You would think that when a miracle drug is available, such as miracle antibiotics for rheumatic fever in the 1940s and GLP-1 medications now for obesity and diabetes, etc., that you would expect that people would jump on board to follow a miracle treatment, and yet we're finding that non-persistence within months of treatment, and 50% non-persistence within a year, is really a problem. and certainly side effects and prohibitive costs are explanations, challenges to convenient availability. But I'm going to offer some more things to be looking at whenever we have patients that have adherence difficulties. Health behavior changes are also certainly front and center in our care. Exercise, we're finding in overall statistics about 25% of people in the United States follow sort of the minimum of recommended guidelines. And the others do not, to the point where about 25% of the population really doesn't move much at all. Healthy eating, again, we're looking at some of the obesity statistics of 3/4 of the United States population being overweight or obese. The consumption of ultra-processed foods, junk foods, can compose even as much as 50% of the American diet. Alcohol use, again, a problem. Looking at some of the statistics on even cancer care, 80% of patients who are warned against the use of alcohol in the middle of cancer treatment may in fact be still drinking alcohol, and a large number of them drinking quite a lot. So the statistics on tobacco, I'm sure aware of those as well. About 1/4 of U.S. population vaping or using tobacco in some way. The challenges of vaccinations and screenings are also presenting themselves. So these things don't go away in the context of caring for patients with chronic disease. Adherence tends to decline as regimen complexity increases. This is kind of an overall rule that we're really clear about. That is, the more complex medication regimens and lifestyle changes that people face, the more difficulty they have with adherence. Treatment tends to improve with higher adherence, but we can't even necessarily count on that. If we look at the statistics, for example, with patients who have IBD, who are on oral medication to prevent flare-ups, we're finding even as much as 60% might be non-adherent to their treatment. So non-adherence is always at the background, always going on whenever we're dealing with behavior change. And okay. Two things that I would like you to keep in mind, and that is that non-adherence can be unintentional or intentional. And I think that's a good way to begin to segment what's going on with your patients. Are patients unintentionally non-adherent because they don't have the resources to follow their treatment? Do they not understand their treatment? Are they super busy in the context of family demands, et cetera? Are the dosing and the scheduling complexities difficult for them? Do they lack the resources even to get to their next appointment? Intentional non-adherence is something different. Patients might be skeptical of the diagnosis. They might feel that they don't quite trust the medical take on things. Some of them are turning to other sources for information. They may be frustrated or bored with treatment, having to make changes for the rest of their lives that can sometimes be kind of overwhelming for many patients. Some are motivated to forget. That is, it's really easy if you really don't want to remember something to accidentally forget to follow a treatment regimen every day, or forget to take medication or a supplement that's been prescribed. Conscious choices are sometimes made to adhere to social media recommendations and the social and cultural group of the individual, which is something we're going to get to as well as we start to unpack what are some of the things that you can do as a clinician and what are some of the things you can look for. Sometimes patients actually make conscious decisions to change their medication regimen, maybe to take half and to save money for that. So clinicians often do not recognize non-adherence. Providers often assume that their patients are behaving rationally. These are some of the things that might be going through their minds. These are not my patients. These statistics come from other patients or other physicians' patients. I can tell which ones are non-adherent, and studies have actually been done of that as well, that clinicians cannot necessarily pick out which of their patients are non-adherent and which are not. Some are reluctant to say anything. I don't want to insult the patient or seem suspicious. And a defeatist kind of perspective, which could occur given how complex the issue is. What's the point of knowing if I can't do anything about it, if I'm going to be just overwhelmed? So patients are playing along sometimes. Often patients will hide non-adherence. They try to get through the 15-minute visit without getting busted. Their providers seem so busy, it's kind of helpful to just not say anything. Patients are sometimes inconsistent across regimens. A patient might be very adherent to some treatments and not at all to others. And it is really rare for a patient to say, I'm having trouble taking the medications you prescribed. Can you help me? So I think we should keep in mind that that direct confrontation or direct request for help from our patients is something that is not necessarily going to be coming forth. Meta-analyses have found that, yes, indeed, adherence matters. And you might be thinking, well, do any of our recommendations matter? And of course, but we have to keep in mind that your recommendations are only going to be helpful to your patients if your patients adhere to them. So it's kind of a given that the medication will work if the patient takes it. We've got a standardized mean effect size of an advantage on the side of treatment adherence in a meta-analysis of a lot of studies. But one of the things that you might find mildly amusing and also kind of intriguing is that there is a placebo effect that occurs. Dr. Ted Kapchuk at Harvard University has been looking at the placebo effect for a long time. And certainly when clinical trials are done in which a real medication is compared to a placebo, obviously we want the real medication to do better than the placebo. And we also want patients who adhere to the real medication. We see this, they do better than patients who don't adhere to the real medication. But what's really interesting is that patients who adhere to placebos tend to do better than patients who don't adhere to their placebos. So their outcomes are better. And that is opening up an intriguing line of research in which we might be trying to figure out, and hopefully we can at some point, what are the benefits of adhering? Are there things that are helpful in the whole process of adhering that may help patients to be more attentive to all aspects of their health behavior and their daily lives? The financial costs of non-adherence are huge, as we know. The costs of disease progression, emergency room visits, hospitalizations, unexpected results of suboptimal treatment. I used to try to figure out the cost to society or the cost to the American healthcare system of 25% of medical advice being wasted. I kind of gave up and I'm leaving that to the economists. But it is an intriguing notion because we do have a sense of the economic costs of lots of things. The human costs are quite large. Obviously, we've got statistics on lots of different areas, particularly hypertension, various kinds of avoidable complications, and antibiotic-resistant bacteria that may result from failure to take antibiotics correctly, and obviously in populations as well. But I want to try to move now from looking at the overall picture to what can you do. And so we'll take the next period of this to present the information motivation strategy model, which is an evidence-based heuristic. Unlike some models of research, which are empirical, statistically based models, this is a model that is based upon a large number of meta-analyses, many of which we did ourselves, our large review of the literature, and a way that we're hoping to offer to clinicians 3 pillars of treatment adherence to keep front of mind in every conversation with your patients. A format that allows you to apply your clinical experience with your patient and your connection with your patient to the challenges of health behavior change and adherence to the recommendations that you've made. Creating for each patient and for each unique relationship that you have with your patient a recognition of the challenges of that patient faces, their strengths, the various questions you need to continue to pursue, and any potential solutions that might be available for that patient. So the information motivation strategy model, which we have segmented here into 3 colors, that will be carried through to the next slide so you can see where the different elements fall into these categories. One of my medical students called this the know, want, and be able model because it's so much easier to remember. Does your patient know what they're supposed to do? That is not necessarily a given. Does your patient understand why they are to follow the treatment that you've recommended? Does your patient want to follow the treatment? It's a given that people won't do things they don't want to do. And that seems simplistic, but as we unpack it, you'll see that there are lots of components to that wanting. And are patients able to follow the treatment? Are they able to follow the treatment and overcome the barriers that exist? Does your patient know what to do? The first piece of the puzzle. It is not a given that patients understand what you're saying when they smile and nod. A number of studies have been done in which patients were interviewed in the waiting room right after the visit, and they have on average forgotten between 40 and 80% of the information you told them during the visit. The after visit summary can be very, very helpful, but many studies show that patients don't use it or they don't read it. Patients' health literacy can interfere with an understanding of it. Their anxiety might prevent them from reading it in the first place, and their pre-existing beliefs and expectations may be something that your advice in the after visit summary needs to be filtered through. What is your patient telling you? Asking the question is really important. Remembering that we have to be clear about not using leading questions, such as, are you taking your medications? Yes, or smiling and nodding. Non-judgment can be very helpful, making it acceptable for patients to admit difficulties, noting that some patients find it hard to take their medications. What are the difficult things that you're facing, or what's the hardest part about following this treatment plan? Holding open lines of communication and listening to what your patient has to say can be extremely important. Being open to recognizing non-adherence. There are a number of red flags. Previously well-controlled conditions might worsen. There might be pharmacy lags in refills, and vague answers to questions about how patients take their medicine. Asking, connecting, being non-judgmental is really important. Low health literacy, obviously, is something to keep in mind. Limiting understanding, recall, and promotion of medication errors. 20% of U.S. adults have low health literacy and up to 36% of seniors. Tailoring information to the patient's level of health literacy and cultural context is critically important. And using healthcare teams, using all of the members of the clinical team to be able to explore the difficulties that patients may be having, to educate patients and find out ways that things might be explained in more in easier to understand language. Communication strategies. I'm sure that you're all familiar with these, the teach-back method, the ask-tell-ask method. And I want to emphasize the key learner who helps you with your health at home. Can you include that person? Invite that person's reading of the aftercare summary. Trust, again, a piece of the puzzle in information. Patients will not follow treatment recommendations from providers they don't like and don't trust. And that's likely pretty rare, but it is very important to consistently be building connections to your patients. Nonverbal immediacy is extremely important. And as we'll note later, some of the technologies available, such as the AI scribe, might allow you to give more full attention to your patients. Your vocal tone, eye contact, facial expressions, again, the entire team that works with the patients, every element, every member of the team. Trust is built with nonverbal communication, as I said, and overall effective communication and meta-analysis shows that 19% risk difference between better communicators and less effective communicators in their patient's treatment adherence. What does your patient want to do is the next piece of the puzzle, or the next pillar of the information motivation strategy model. Patients follow treatments they want to follow. One of your goals is to help your patient to want to follow the treatment. We think of motivation as just willpower, but it is essentially an outgrowth of a collaborative partnership between the clinician and the patient, as well as joint decision-making in which clinician and patient work together to examine the risks and expectations. One of the models that I think most of you will remember from college and public health and medical school, etc., is the health belief model. And this is a model which was really a foundational statistical and research model that has guided us for 60 years already in understanding the role that what's going on in the patient's mind is going to be driving the patient's choices about what they want to do, how they perceive the severity of their disease. Do they think it's even important? Do they perceive that they are susceptible to problems that might occur? And how do they see the utility versus and the benefits versus the costs of their treatment? So while motivation is partly internal in terms of cognitions, it is also social. Patients examine the driving forces in their lives. And it is really important for us to understand what the factors are that are driving patients' beliefs, such as subjective norms, their families, their friendship networks, their cultural beliefs and expectations, and recently, so incredibly important, social media. And so behavioral commitments influenced by what family, friends, and peers think the patient should do, including the entire World Wide Web of input. We know that messengers can be more or less persuasive. Doctors' orders, while competing with loud, sometimes, and quote, trustworthy voices, or voices that patients trust. The persuasive clinician, it should be remembered, is also someone who has expertise and is respected by the patient and has a personal relationship with the patient. So while the social media voices might be doing some competing, it is also critically important to recognize the central importance of the clinician and of every member of the healthcare team in terms of affinity and trust, familiarity and likability, and of the reciprocity that occurs in human relationships. Messages can also be more or less persuasive. As you frame messages for your patient, try to figure out kind of what your patient's expectations are, what they think is going on, what you can communicate to them might be problematic, how they view their own personal beliefs and whether those are consistent with the actions you're asking from them. Do your patients, how do they respond to fear induction? Research shows that mostly telling patients if they don't follow their treatment, really terrible things are going to happen, and trying to kind of get their attention with fear-based messages is actually not helpful. More toned down messages that might provide a problematic potential outcome with clear action steps can be a lot more helpful and persuasive. I want to note the salience of teachable moments. You've heard lots of points about teachable moments, and sometimes your patients may say to you, oh, I have a friend who has this, or I have encountered this kind of situation in the past. They might even tell you a clue to family history that you didn't know. In any case, what patients feel is salient in their perspective on the condition is something that you can actually work with. So pay attention to the stories that your patients tell you as your patients frame their understanding in terms of stories. The lay referral network is something that health sociologists, medical sociologists talked about again 50 years ago, and that is the informal network that was consulted usually in the neighborhood. Now that informal network is absolutely huge. The AI and social media and what people lovingly call Dr. Google. I guess the question that's important to ask yourself and to talk about perhaps with your medical team is your healthcare team, is it good or bad idea for your patients to be consulting the internet for advice, and how can you help them to better use that? For example, perhaps to make a list of questions that could be used in the clinical interaction that will help to clarify a lot of issues for you. Many of the reasons that patients give have to do with both lack of access and lack of trust. I want to just mention that sometimes behavioral management is difficult for patients. It seems overwhelming. It's not as fun as the idea of being cured, which a lot of times patients turn to medicine for. The changes that occur day to day in behavioral management are sometimes difficult, especially if they're thought to be long-term for patients. Many people believe that incremental change is really what they prefer to have. I'd like to get the next slide. Quantum versus incremental change. Quantum change offers abound. People offer, 3 steps to the management of your diabetes without medicine, etc. So there's a lot that you're working against, and I understand that those kinds of things can be very difficult. Training oneself out of bad habits, maintaining goals, and working ahead with self-efficacy can be challenging. Okay, the stages of change model. I know a lot of you are familiar with this. I'm going to go through the next few slides a little bit quickly because we're coming up on the time. But all of you know about motivational interviewing and the application of the stages of change model. The thing to remember about the motivational interviewing and the stages of change model is that people don't go from doing nothing to perfectly complying or adhering to their treatment. That often individuals start with pre-contemplation. They think of themselves as, maybe if I were the person who followed their treatment regimen, this is something I might do. But I'm not going to do it. And then as people begin to move into noticing that other people perhaps are walking or exercising, they might begin to move into preparation, and then eventually into perhaps following colleagues at the office to go for a walk during the day or something to that effect. And so maintaining the behavior change over time, likely to fall into relapse because of unbeknown factors such as snowstorms and other things, but getting back onto the behavior change is really important. I want to mention the importance of depression. Approximately 30 to 50% of patients with chronic illness have comorbid depression, and patients from meta-analyses have been found to be 3 times more likely to be non-adherent because of the pessimism, hopelessness, cognitive challenges, difficulty planning, and social withdrawal. Hopefully you will be either screening using something like the PHQ-2 to screen for depressed mood and anhedonia, or perhaps incorporating some of the questions from the PHQ-2 into your daily conversations with your patients. What you can do, of course, is if your patients are scoring high on this, to delve further into the PHQ-9 or into the MHI-5, which would also include some anxiety questions. Next slide. Okay. Serious illness paradox. Research has found that while we expect patients to be better at adherence as their disease progresses, in fact, studies show that patients who are in objectively poorer health are often less adherent. So what is the patient able to do? And this is the third piece of the puzzle. We need to look beyond the patient failed the treatment plan to the barriers to treatment adherence and health behavior change. specific barriers that patients face. Each individual faces often a constellation of practical difficulties and lack of resources. Some of those practical difficulties might involve the following kinds of things. Usually, by the way, these are correlated with socioeconomic status because of resource limitations, and we see a list of these here. I want to draw your attention to things like work schedules, the needs of family members, time and the funds and the energy that are involved in preparing fresh foods that we recommend to our patients for their diabetes management or for their heart disease management. Transportation is a really important thing that we forget about sometimes, as well as even when patients have access to the internet, do they have consistent and reliable internet access? And there are a few unique features a patient might not feel comfortable mentioning to you. They might even be embarrassed, such as fear of needles or difficulty swallowing pills. So those are the kinds of things that are important to be aware of and keeping attention to all the time. Regimen complexity, again, I think you probably are always putting in an eye towards this, simplifying the regimen, reducing pill burdens, helping patients with strategies, making suggestions for how they can pair their medication with daily activities, helping them with reminders for some patients who are tech savvy with tech reminders and smartphone reminders, and building behavioral habits by linking various behaviors and treatment regimens together. Recognizing the importance of cost barriers and side effects for your patients, the financial strain that many of them face. This is often a major driver of intentional non-adherence and helping patients to find affordable medications. Recognizing also that side effects are really important to many patients, respecting the patient's point of view and their own unique quality, take on their quality of life, that a patient might be more or less sensitive to a side effect than your other patients, and recognizing that there might be ways for you to help your patients to make side effects manageable, making sure that you know about these to begin with. Using adherence and enhancing tools, the old standby smart pill box organizers and smartphone alerts, and other things regarding prescribing, such as 90-day refills, confirming patients' adherence to all the medications before adding any more, and linking patients even to community resources. Social support is something I want to emphasize a lot, and that is that meta-analyses, a number of them, have looked at the importance of social support. Almost 2.5 times higher odds of adherence among those who have 2.5 times higher adherence among patients with social support than those who do not have social support, because social support provides encouragement and supervision, although it's really important to remember that reminders without nagging are the most helpful, and even modeling, such as modeling evening walks with family members and friends. We can segment social support into 2 types, practical and emotional. And interestingly, while it's really very helpful to have encouragement and listening to one's fears and frustrations, you see the slightly increased odds of adherence. Practical support is where it's at. Assistance with chores, reminders, transportation, asking your patients who they have, who might help them to do all the things that are imperative for them to follow their treatment can be very, very important. Family dynamics. While close others, as we've said, can be a tremendous asset, we have family support networks. When families are supportive, the odds of adherence are higher. They can also be a liability. When patients are in the context of a family that's characterized by conflict, their risk of non-adherence goes up significantly. Obviously, culturally informed care is critically important, and I know that you're all tuned to this all the time. Medicine essentially is a clinical social science as you look at all the ways that patients are embedded within a cultural framework which guides their everything from food preferences to patterns of exercise, views of medicine and science, etc. So obviously that is a critically important element of strategy. I want to mention a couple more things in the next slides. Keeping in mind that so much of this work is done by teams who work together to help patients with behavioral management and to integrate health behavior promotion into practice at every single level when there's a touch point with the patient. There are also potential tech solutions that can allow patient clinician interaction to go more smoothly so that connections can be greater, and digital tools such as apps that the patient can use to help them and consistently encourage them to increase their physical activity and to remind them for the medications and for eating healthy foods. I want to mention the next slide. I love this. This is just the whole model of chronic care that I know many of you are familiar with, the work of Ed Wagner at the University of Washington, in which he uses the analogy that oftentimes we send patients out in our chronic care to care for themselves, much in the way that a flight instructor might give a aspiring pilot one flying lesson and then send them out with a manual and the directions to call the tower if they have any problems. That's kind of the way that traditionally chronic care management has been carried out. Patients feel like they're often on their own. Lots of interesting studies, many referenced at the bottom of the slide, have looked at the incredibly strong evidence base support for the integration of behavioral mental health care with primary care, recognizing the importance of screening, such as we mentioned, for depression, for anxiety, for various difficulties in the facilitation of referrals in the community, and collaboration among multiple providers in care decisions. Always keeping in mind, again, to harken back to Dr. Saber's presentation in December, patients are embedded within a social ecological framework. Their entire life space is relevant. Who is your patient as a person? What matters to them? What do they believe? How do they live? What are their health habits? Are they depressed, hopeless, anxious, or discouraged? And what are the resource limitations that they face? And what stresses are on them? So it is my hope that the information motivation strategy model, or the know, want, and able model, will allow you to keep front of mind and uniquely kind of modeled for each patient. What does your patient know? What do they want to do? And what are they able to do? Always aware that adherence is a process dependent upon two-way communication, collaborative decision-making, and most of all, trust and empathy that are foundational to treatment adherence. Thank you.
Thank you so much, Dr. DiMatteo. Really appreciate that. Great discussion on adherence and some of the challenges that we face on a regular basis. We have a couple of questions. I think for a lot of us, the challenge of social media, AI, Google, etc., is a very real part of caring for people on a daily basis. What strategies do you recommend when patients are bringing information from these sources to their visits, and they may really have a lot of trust or belief in the sources that they're bringing information forward from, and how do you manage when that sort of balance, when the information may be myth, not fact, but yet they are kind of committed to the framework that they're bringing to you?
Well, certainly it's a huge challenge, and I think that probably the first thing to remember and keep in mind before you say anything is don't deflect. It's easy for us to react, I think, almost emotionally to something that really sounds absurd or that could even be dangerous for the patient. The thing to accept is not the content, but the patient's frame of mind. That is, recognizing empathically that your patient is searching for an answer, keeping front of mind that your patient is usually scared and confused. They're facing an illness that they may have to deal with for the rest of their lives. Acknowledging that, I think, is probably the first step. Respecting the patient's attempts to find answers and acknowledging again that the patient is trying to be proactive in their care. Pointing out as you try to become again the most trusted messenger in this, pointing out what some of the difficulties might be in the way that things are being looked at and offering another perspective. Keeping that, I think, is foremost in this whole perspective that I really think is critically important, really, truly essential, which is empathy and trust. Keeping that trust in the relationship so the patient is not perceiving you to be against other points of view, but rather you are in a relationship with the patient and connected to that patient, and you want the best for them. And what you know from, and you could gently remind the patient that you really do have a lot of expertise in this care, that you have lots of patients who are struggling with diabetes or struggling with heart disease as well. And you appreciate their proactivity and their desire to care for themselves. Many of your patients want to do that. And you want to be sure that they are getting what is really the best evidence. And that is where then the discussions about the evidence base come in. But I think it's really important to start with empathy, start with listening, start with supporting what it is. I mean, find something good about what the patient's doing, even if it's that they are looking for solutions and trying to motivate themselves to take care of themselves and work with that so that you are providing the evidence at the same time you're keeping the patient in the fold in a sense.
Excellent. Thank you. Moving from high tech to low, would it be possible to share some low tech options for medication adherence and examples of community resources that might help with this issue?
Well, the lowest tech ones that have been tried and true for many years and were studied back in the day when the very early research on adherence, writing things down for the patient, having a piece of paper and either having pre-printed points you'd like to make and checking them off uniquely for that patient, or if your handwriting is pretty good, writing them out, or helping your patient to write them out. You want to keep the progress of the visit flowing and not take a lot of time to do that. So I think there might be ways that you can provide those kinds of low-tech solutions, but there's sort of nothing like pen and paper. You could have help your patients to understand the best ways to use pill containers, reminders that they could give themselves. I mean, recommending to your patients the simplest things, sometimes notes on the refrigerator, checklists. I know that's, you asked for very low tech, so that's the low tech stuff that has been found to work really, really well. As far as community resources, I think that it varies by community. Certainly senior centers sometimes have classes on how to manage your and fill in the blank for the chronic condition. The web can actually be very, very helpful. And you could even, if you have, for example, a member of your clinical team anyone who is tech savvy who could help the patient to download an app into the smartphone. Even senior citizens are going to probably have a smartphone they may not be utilizing to its fullest extent. If you have a young person in your office or anyone who can teach them to download an app that can encourage them and remind them to exercise, give them feedback, one of the simplest ones that's available may just do the trick.
Thank you. And one of our other attendees also suggested an adherence contract with pictures. I assume that's of the medications themselves, just easier ways for patients to know what we're talking about when we're making lists. Another question about a very common medication situation. Can you provide any tips around the problem that is the public perception of the statin medications for cholesterol, and how many times patients will come in expressing that the medications might be harmful and that the medical system and the providers within the medical system are the ones creating harm to the patients with the use of these medicines?
That's starting off an interaction in which a patient says that is already really difficult. So the first thing that I would recommend is breathing, because that, in a sense, is an attack on the whole medical system. So stopping for a second and recognizing that patients are inundated by these messages. So they might be bringing that to you because that is really what has been flooding their minds. I think that downloading some of the most recent research on the safety of statins and having an article or so about this that you might even have available for your patients, if you can provide a some written materials about the role of statins. I think that what you've asked about is not just the issue of statins, but so many things, because so many of the quantum change messages that are out there are actually not only inaccurate, but also really go against the sort of the mission of medical care and healthcare. And it's really difficult. I think it's important to acknowledge what it makes you feel when a patient, whether they're talking about a statin or something else, is communicating something like that to you. And then providing, again, your perspective as an effective messenger, and also making sure that the message is something that the patient can at least listen to. And keep in mind, again, the stages of change model. Just because you say something and the patient doesn't change right away doesn't mean they're not going to be thinking about it. They're not going to be moving along those dimensions at some point, perhaps noticing someone else that they actually know and respect is taking a statin. And that person's doing pretty well. And my doctor showed me some research that said that statins are helpful and safe. So there's this interplay. Again, there's not kind of a switch. The patient is adherent or not. There's this problem or not. It's again a process. And honestly, the best thing you can do is breathe and check your own pulse first, and then move into that. Interpersonally, that's probably one of the most difficult clinical interaction starts that I can think of. I'm sorry.
Thank you so much. We really appreciate you being here today. We had a couple of folks ask about recording and slides. Those will be made available on the Cardi-OH website. And I want to thank Dr. DiMatteo for talking with us about a challenging issue in adherence that I assume we will be facing over our careers. I am going to turn it over to Sherry Boland to wrap up for us. And I want to thank everybody very much for being here today.
Thanks, Dr. Zack, for helping to moderate. Thank you again, Dr. DiMatteo, for joining with us today and talking about such an important area. And thanks to all of you for joining with us as listeners. Just a reminder that if you wanted to get CME and you missed this earlier, you can use the QR code here or the URL in the that we're putting in the chat now to register and express interest in getting a CME, and then you'll receive an email from Cloud CME in the next few weeks. And we do want to hear from you. We're going to have a brief survey that you can take. That will be, there'll be the link there. And then also you'll get an email. We want to hear what went well and what you think could be improved as we continue to provide webinars in the future. It's very useful for us. Next slide. And then just if you want to learn more about cardio.org, just go to our website. We have lots of different resources there. We will, as mentioned, have slides and recordings available in a few days as well for this talk. And you can follow us on social media as well. So thank you all. Have a wonderful afternoon.